right, welcome to The Explainer. Today, we're going to crack open the absolute workhorse of our entire field, the X-ray tube. We're going to strip away all that complex physics and turn it into a practical guide you can actually use, like, on your very next shift.
So let's just dive right in with a scenario that, every resident has faced, right? You get a chest X-ray, it's blown out, it's blurry. What do you do? Is it the patient? Is it the machine? Figuring that out is exactly what we're here to do. By the end of this, you'll know exactly what went wrong and how to fix it.
Okay, so to get to the bottom of that question, we've got to take a step back and look at the photon's journey. I'm talking about what happens before it even leaves the tube to go to your patient. It all happens right inside that little box. And honestly, it's way simpler than you probably think.
And here it is, the whole process in a nutshell. It really just boils down to 3 simple steps. First, we make some electrons. Then we speed those electrons up, like really fast. And finally, we slam them into a target to convert them into X-rays. That's the whole magic trick. Let's break down each of those steps.
Okay, step 1, we gotta make the electrons. This process has a fancy name, thermionic emission, but the idea is simple. Think of a light bulb filament. We take a tiny tungsten wire, we heat it up to over 2,000 degrees Celsius, and it literally starts to boil off a cloud of electrons. Just like that, you've got this little cloud of potential just waiting to be used.
And here's the cool part. You control this directly. That MA setting on the console, that's your knob for this step. It's basically the thermostat for that filament. You crank up the MA, you get more heat. You boil off more electrons. And what does that mean for your image? It gets brighter. So just think of MA as your brightness knob. Pure and simple.
All right, step 2, speed up those electrons. We've got our cloud, now we need to give it some serious juice. We do this by applying a huge voltage. We're talking kilovolts across the tube. This creates this incredibly powerful electric field that just grabs those electrons and launches them across the vacuum. We're talking nearly half the speed of light. All that speed gives them a ton of kinetic energy.
And guess what? You control this part too. That's your kVp knob. The higher you set the kVp, the faster those electrons go, and the more energy the final X-rays will have. And why does that matter? Because that energy is everything. It controls how well the beam can penetrate the patient, and it dictates the contrast of your image. So remember, kVp is all about penetration and contrast.
And that brings us to the final step. Step 3, convert to X-rays. So you have this stream of super fast electrons, and they just violently slam into a rotating tungsten target called the anode. It's this incredibly sudden stop, this brutal deceleration that converts all that kinetic energy into photons. But, and this is a big but, the process is, well, it's shockingly inefficient. Just look at these numbers. It's wild. A staggering 99% of all that energy we just built up, poof, it's wasted as heat. Only 1 tiny percent actually becomes the useful X-rays we need for our image. This is the reason why managing heat is the single most important job in keeping an X-ray tube alive and working properly.
Okay, so that's the physics. But how does this actually help you on a Tuesday morning when you're trying to get a good portable chest? Well, it all translates to the 3 main levers you have at the console. These are your controls for image quality, for patient dose, and for sharpness.
The first one, and you could argue it's the most important, is kVp. And with kVp, you are always facing a trade-off. If you use a low kVp, you get this gorgeous, high-contrast black and white image, perfect for seeing that tiny fracture in a hand. But if you try that on a chest, you won't see a thing. For that, you need high kVp for its sheer penetrating power to punch through the mediastinum and actually see the lungs.
Your second lever is MAS. Now, MAS is really just a combination of MA, the brightness, and the exposure time. And here's the trade-off. For something that's moving, like a breathing patient or a squirming kid, you need a super short exposure time to freeze that motion. That means you have to crank the MA way up. But for something that's not moving, like a hand, you can use a low MA and a longer time. And the big advantage there, it lets the system use a smaller focal spot, which, as we'll see, gives you a much sharper image.
And that leads us perfectly into our third lever, the focal spot. Now, most of the time, the machine picks this for you based on your MA setting. And it's a very straightforward trade-off. A small focal spot gives you incredibly sharp images, perfect for seeing fine trabecular bone detail. The problem? It can't handle a lot of heat, a lot of power. A large focal spot, on the other hand, can take the heat, it can handle the high power you need for thicker body parts, but you pay a price in image sharpness.
Okay, so we've got our 3 levers.
KVP for penetration and contrast, MAS for brightness and motion, and the focal spot for sharpness. So, how do we actually put all this together to choose the right settings for the perfect shot, in the real world?
Think of this like a little cheat sheet. It really shows how your clinical goal drives your technique. For a chest PA, what's the goal? See through the mediastinum. So the key factor is penetration, and that means high KVP. For a hand, the goal is max bone detail. That means we need high contrast, so we use a low KVP. And for a big lateral lumbar spine, honestly, the goal is just getting the beam through all that tissue. That means we need max power, high KVP, and a ton of MAS.
And here is a golden rule, a fantastic pearl you can use every single day, the thickness rule. It's a great rule of thumb. For every 4 to 5 centimeters of extra patient thickness, you have to double the MAS just to maintain the same exposure. This is so important for portable exams, where you go from a 50-kilo patient in one room to a 120-kilo patient in the next.
But hey, let's be real. Even when you have the perfect plan, things go wrong. Images come out bad. So let's do a quick fire round on how to troubleshoot the most common problems you're going to see.
All right, first up, the classic. The image is way too dark. It's underexposed. You can't see anything. What do? Well, your number one move should be to increase the MAS. It's the most direct fix. You double the MAS, you double the brightness. It's that predictable. Now, what if you also felt like you weren't penetrating enough? Then you could increase the KVP. And a great little trick is the 15% rule. A 15% increase in KVP will roughly double the exposure. Just remember the trade-off. You're also going to lose some of that nice contrast.
Okay, next problem. The brightness is fine, the exposure is good, but the whole thing is just a blurry mess from motion. Now what? There is only one fix for motion blur, and that's a shorter exposure time, period. But if you cut the time, you have to increase the MAs to keep the same MAS, right? To keep that brightness. And there's that trade-off again. Pushing the MA that high might force the system to use the large focal spot, meaning you solve the blur problem, but you might give up a little bit of sharpness in the process.
So what's the big takeaway here? It's that understanding these basic principles, it takes you from just being a button pusher, just taking pictures, to actually engineering an image. When you really master the tube, you're mastering the absolute foundation of diagnostic radiology. So I'll leave you with a question to take with you on your next shift. We know now that every single image is a compromise, right? It's a balance between image quality, patient dose, and maybe even how fast you can get the exam done. So, knowing what you know now, what's the one compromise you'll think about differently tomorrow?